live now.
Hi everyone, welcome to Pre-Dental Universe. Today we have Dr. Amanda, and she's a pediatric dentist, and she'll be sharing her journey with us. Thank you again, Dr. Amanda, for joining us.
My pleasure. Thank you, Pre-Dental Universe, for having me. I'm really excited to talk about my journey and go over some cases with everyone today. So hopefully everyone finds some value from the presentation. And like Jay was saying, I am a pediatric dentist in the Bay Area in California. So once things start to open again, if anyone's interested in shadowing at my practice, I'll include my contact information at the end of the presentation. So first, let's go over my journey to where I am today. So a little bit of background. In my family, my dad is a cardiologist and my mom is a nurse. So I've always kind of loved the science field, but I wasn't sure if I wanted to go into medicine. And in the summertime, I'd always work with kids at summer camps and things like that. So I definitely was drawn more towards the pediatrics field. And my best friend, actually growing up, her dad was my dentist. And so we always joked, one day we're going to grow up and be dentists together and take over her dad's practice. And she ended up not wanting to go into dentistry. But I was still really interested in it. Then when I was 14 years old was when I finished my braces. And that's when I really started getting interested in dentistry and possibly becoming actually an orthodontist. So I would do braces. So this kind of led me to my senior project in high school, and I decided to do my project on dentistry. So I shadowed my dentist, and I developed a program to go over oral hygiene instruction with first graders, which was really fun. And I also was introduced to Give Kids a Smile. So Give Kids a Smile is a program that was launched nationally in 2003 to provide underserved children with free oral health care. And over 6 million underserved children have so far received free oral health care from this program. It usually takes place in February, which is National Children's Oral Health Month. And so I've participated in this program ever since I found out about it in high school. And it's just a really great program where you get to work hands-on with children providing dentistry, which has been really fun. Then when I went to college and dental school, I also did a lot of extracurriculars kind of related to dentistry. So I got a lot of hands-on experience to kind of see what area of dentistry I wanted to explore further. And one of them was CDA Cares, which is hosted by the California Dental Association. And this program actually allows volunteers to provide dental services to about 2,000 children and adults over the weekend. So that was really fun. I always liked working in the pediatrics area if I could get over there, if they needed volunteers. And then at Dagoni Dental School, we also had what's called Pacific Pride Day. So that was really fun. It actually just happened last Saturday. And it's an annual open house for prospective students to kind of tour the school, meet the faculty, the staff, and the students. You get to see the simulation lab. You get to practice doing dental impressions. So lots of hands-on experience. This year they did it virtually, so definitely look out for that because I think a lot of dental schools are doing virtual options this year. And I was also really involved in Club Scope, which is the student community outreach for public education. And so that was also where we would go do oral hygiene instruction in the community. It was usually at either health fairs or at classrooms. So I always tried to volunteer for the classrooms to work with the kids as well. Then in dental school, I actually was fortunate to have the opportunity to go on 2 dental mission trips. And so the first one that I went on was to Jamaica. And this was such a humbling experience to see people. They would line up. You can see the line in this photo. They would line up for so long just to get maybe like 1 or 2 teeth fixed while we were there for the week. And it was such an incredible experience. And I was actually lucky. One of the faculty that was there on the trip was a pediatric dentist. So I got to work with him a lot as well. And then when I went on the Fiji dental mission trip, they actually had a specific pediatrics day. So that was my favorite day. So as you can see, I'm sort of trending towards pediatrics throughout my whole journey here. And so personalized instruction programs, this was specific to Dagoni, and it was a new thing when I was in dental school, but I believe it's a requirement now. It was optional when I was in dental school, so that's a while ago. And so I did 2 programs, and the first one I did was a survey on my dental mission trips, and I also included the surveys for students who went on the Philippines dental mission trip, and we were looking at the correlation between sugar in the diet and cavities. And so we did find a correlation between the two. So I was really interested in kind of getting to the root cause of the cavities, because it was so sad for me to see that we could only fix a few of the teeth for the kids while we were there. And so by doing a lot of oral and hygiene instruction programs we were there, we were hoping to make a bigger difference and hopefully changing some of their habits and things that were causing cavities for them. And then my second program that I implemented was an oral health program for elementary school level children. And then I worked with another dental school classmate, and she did the oral health program for the adolescent age children. So this is just some photos from the pediatrics day in Fiji. Okay, and then the last thing that I wanted to talk about for this part of my journey was I did an externship. So you can see if when you're in dental school, if you can do this. I went to USC and Children's Hospital Los Angeles, and it's considered a dental hybrid program for pediatrics residency. So it's part university program and part hospital. And this was a really good firsthand view to see what pediatrics residency would be like. I got to go into the operating room. I got to see sedations. I got to meet the craniofacial team. And I just got to meet a bunch of the faculty. And I went with one of my dental school classmates. He's actually a pediatric dentist in Reno now. So I think it's great if you can just keep an open mind, even going into dental school, because you'll get a lot of great experiences to kind of decide if you want to go into general dentistry or if you want to do something like teaching. There's lots of different things you can go into. So I'll kind of go over that more as well. So just to kind of summarize my education, then I'll go into a little bit more detail. So I went to University of the Pacific for my undergraduate education, and I was part of the 3+3 program. So I did 3 years there, and then I did 3 years of dental school at Degoni School of Dentistry in San Francisco. And then I did my 2-year pediatrics residency at Cincinnati Children's Hospital Medical Center. So I did leave California for 2 years and braved the snow. Okay, so this is a little timeline of my education. So I think I kind of mentioned since I was 14 years old, I knew I wanted to be a dentist. I just wasn't sure which specialty. And so I knew I wanted to go to Degoni once I started doing my research. And I was accepted into the 2+3 program, where I would have done 2 years of undergraduate school and then go on to dental school. But a lot of my mentors, my dentists, my orthodontists, they all said, take the 3 years, take some extra courses to help make dental school a little bit smoother for you and get some more experiences. So I was able to actually do a lot of volunteering, like I mentioned, and I was able to study abroad for a semester in Italy. So I'm really glad I kind of took that 3rd year to have undergraduate experiences. Besides Give Kids a Smile, I was involved in the Beta Beta Biological Honor Society, the Pre-Dental Club, and I did graduate with my BS in biology as well before going to dental school. And then in 2011, I came back from Italy, graduated, and then a few weeks later, I started at Degoni Dental School. And then, like I mentioned, I did go on those 2 dental mission trips, so Jamaica and Fiji, while I was there. And Degoni, they consider it a year-round dental school, but talking to my friends who went to other dental schools, I feel like we got the same amount of breaks or maybe even more. It just kind of depends, like, on the year. Sometimes you have 3 weeks of winter break, sometimes 2 weeks, but it just kind of alternates. And then what I really loved about Degoni Dental School is very humanistic. So they treated you like a doctor from day one when you walked in the door. Degoni was really big on that. It was a lot of hands-on learning, which is how I like to learn. So that was really important for me. And it was in California, and my family's here, so that was really important to me as well. So in 2014, I graduated from Degoni Dental School, and then I started at Cincinnati Children's Hospital Medical Center for my pediatrics residency. So that's the picture of me when I was in the operating room with Dr. Wilson, who was the program director at the time. And Dr. Sarat Thakirshi was also there as one of the clinical directors. And Dr. Wilson, actually, he wrote the sedation guidelines for dentistry. So I was very fortunate to learn from both of them, and we did a lot of sedations. We got a lot of special healthcare needs cases from around the world, so I got a lot of unique experiences, which was what I wanted out of residency. So I loved my time there, and it was very similar to Dagoni in that it was a very humanistic approach. So I loved my time there, and then after 2016, when I graduated, I moved back to California. And I've kind of been here ever since, working at different practices. I'm now at one big practice. We have 3 locations. So I can kind of talk about that a little bit more later as well. So I want to get into some advice for you guys before I jump into the cases. So let's see. So the first thing, some of you may be going through this right now, depending what year you are. So yes, your GPA and your DAT scores are kind of like the first barrier you have to get through. So I did like the Kaplan prep course, cracked that PAT. I think those are both still around. There may even be new things as well. I was lucky being part of the 3+3 program. When you get accepted into this program, if you meet a certain GPA and DAT requirement, and you are actually guaranteed an interview at Dagoni Dental School. So that was kind of my main draw for going into UOP for undergraduate school as well, besides the fact that it was close to my family. And then the second thing I want to go over, I'm sure all of you, is an intense caseload. And so if you have those good habits going into it, it's definitely going to help your stress level and time management as well. While you're in undergrad, definitely explore lots of different opportunities. Volunteer when you can, take part in clubs, and just do a lot of networking. And it'll kind of help you see what you're interested in once you get into dental school as well. And I mean, I still have so many great friends from undergrad, and I refer to a lot of them. So it's definitely a small world in dentistry. And we were kind of talking about this before we started, but I think it's wonderful that you guys have access to virtual shadowing now. So hopefully you're getting to have exposure to different specialties as well as different practices, because one practice compared to the next could be completely different. So there's lots of different types of dentistry you can take part in. So it's wonderful that you guys have access to this now. Try to expand your horizons. Do as much traveling as you can, studying abroad. I know the pandemic kind of may have limited that a little bit, but just read books, do research, join clubs, do sports, do all of those things while you can, because not to say you don't have free time in dental school, but dental school, you definitely have, I would say you have to kind of manage your time a little bit differently than undergrad. So definitely take advantage of this time now. And then my last thing I really like to go over is self-care. Dentistry is not only, there's a lot of mental and physical components to dentistry. So you want to make sure you have a good exercise regimen, get your diet, do yoga. That's one thing I wish I had started earlier before I went to dental school, or even just stretching, and figure out how you manage your stress. I was a big runner, so that kind of helped me a lot in dental school. So just kind of figure out all of that out while you can now. And definitely enjoy your breaks, your summers. You don't need to pre-read any textbooks for dental school or anything like that. You'll definitely get enough of that once you're in dental school. Okay. And so some of you, I don't know if you've seen my Instagram, but I'm really big into sustainability, both in life and now specifically in dentistry as well. So I just wanted to touch on this a little bit. And if anyone has any ideas or they're interested in learning more about this, you can definitely reach out to me. So green dentistry is actually an approach to dentistry where you reduce your dental practice's environmental impact. And I think over the past few years, we've seen a lot of companies are working on that, but this is kind of a newer concept for dentistry. But basically, green dentistry will encompass a service model that supports and maintains the wellness of not only the patient, but also the planet. And so just a little bit of context for you guys. 1 billion toothbrushes are thrown away each year in the United States, and this is enough to wrap around the earth 4 times. And so actually by switching just to a bamboo toothbrush, we can prevent 50 million pounds of toothbrushes from going into the landfill in the US annually, which is a significant reduction in plastic. So that would be awesome if everyone can make that switch. And the second thing, we kind of all saw this with the pandemic, but every month 129 billion face masks are being used. And unfortunately, millions of them are ending up in the environment. So my little PSA is make sure you cut the ear loops on your face masks if you use disposable ones. If you have reusable ones that you can wash, though, that's even better. And then just kind of a basic environmental mantra is just reduce, reuse, repair, and recycle where you can. And in dentistry, just as in medicine, it's kind of hard to reuse because of sterilization and everything, but luckily there's a lot of recycling programs that are coming out. So hopefully by the time you guys go to dental school, this will be a bigger part of the education. Okay, so just really quick, my disclosures. I don't have any financial disclosures, and all the cases I'll be going over, we've received consent from the parents or guardians. And this presentation is just for education, and these are just my own opinions, and no duplication should be made. Okay, so let's go over what a typical day looks like for me. So I think a big difference between pediatric dentistry and general dentistry is we see a lot more patients. Average is probably 30, 40 patients a day, but in the summer it can be 50, 60, 70 patients a day. So it's definitely a quicker pace, which some people love. I love that. I get to see a lot of kids in a day. And then my schedule right now, I'm doing 4 days a week. So like I said, we have 3 locations. So I do 2 days in each location. And then 1 Saturday a month, I go to the 3rd location. And because we have 5 doctors, pediatric dentists in our practice, we usually rotate call monthly. So just if parents have questions after hours or on the weekends or on holidays, that's how we kind of rotate. It's pretty rare that we have to go in, considering we have 3 practices. But again, just as if you were a general dentist, or I would say oral surgeons probably have the most busy call, but there's definitely emergencies in pediatrics. Every time I was on call in residency, I had to go in because I was associated with the hospital program. But in private practice, it's a little bit different. And then we also do general anesthesia cases once a month. Each doctor has a day. So that is where our patient is completely asleep and we're doing all of their cavity treatment at one time. So usually about 2 hours per case, and we'll see anywhere from 2 to 5 cases, but the child can't eat so many hours beforehand. So it's kind of harder for kids to get them to not eat by the afternoon. So that's a little bit more challenging for our later patients. So we start off the day, we do a huddle. So we go over any significant patient concerns or anything that's going to be happening that day. And then I also like to review my patients at least the day before to kind of go over their medical histories, kind of see what treatment I'll be doing. So I can let my assistants, if there's anything special I need set up. I included kind of a sample of what my schedule looks like. So you can see, and every dentist does a different layout. This is how my boss kind of has us see patients. So I have 1 treatment column, and we usually schedule an hour per treatment. And this is not only for breaks for the child, but also so we can jump out of the room and go check on our cleaning patients and see if they have any cavities, read x-rays, and go over oral hygiene instruction, all of those things. I'll go over this more later, but silver diamine fluoride, that's SDF. So that would be in our 30-minute time slot. We do schedule new patients for an hour because we go over a lot more with them and a lot more education for their first visit. And they usually have a lot more questions as well, their first dental visit. And then this would also be where we do office visits. So if they're coming in for a specific concern, so I'll go over some examples of chief complaints later. And then also follow-up. So if there was a trauma, we have certain follow-up requirements for them to come in maybe 1 week or 2 weeks or 6 weeks. So that would also be in one of the other columns. And so this could be 2 columns of recalls, 3, 4. It just kind of depends on the staff you have, the size of your office. and also the demand from patients as well. Okay, hopefully my video will work, but this is a quick little tour of one of our pediatric dental offices. Okay, so this is our front desk, and then we have a cute little door for the patients to go through. They love that. And then you'll see right here is our consult room. And then we do have some treatment rooms, or we call them quiet rooms. So they're closed off for soundproofing. And then we have our open bay with the benches. So that's where we would do those cleaning visit appointments. Okay, so let's get into what is pediatric dentistry. So pediatric dentistry is actually an age-defined specialty. So it could be from infants and children all the way through adolescents. Sometimes, if they don't have adult tooth dental needs, we'll see them even through college. If parents are like, please, can they stay with you? They don't want to come to my dentist yet. So it just kind of depends. But we do provide primary and comprehensive preventive and therapeutic oral health care. And we do, like I mentioned, we do a 2-year specialty residency. And during that time, our training is in child development, taking care of special healthcare needs patients, behavior management, oral sedation, IV sedation, general anesthesia, and we also get a little bit of orthodontics as well. So these are some of the diagnostic tests and instruments that we use throughout the day. So during a comprehensive exam, we would look at not only the general health of the patient, but also their growth, any chief concerns that they have. I'll give some examples. And their extraoral soft tissue, their TMJ joint, their intraoral soft tissues. And then we also look at their oral hygiene, their periodontal health, so that would be their gums, intraoral hard tissues, so that would be looking at the teeth. They're developing occlusion, their risk for getting cavities, and then also their behavior, which is super important in pediatrics. So when we go through the patient history, we go over things like when was the last time they went to the dentist, how do they do when they go to the pediatrician. It kind of gives us an idea of how they're going to do at the dental visits. What is their oral hygiene like? Have they had any trauma to their mouth? Are there any habits like thumb sucking or using a pacifier, teeth grinding, things like that? We like to know. And then we do have digital radiographs or x-rays that we take, and compared to most like general dentists, we do have smaller x-ray sensors that we can use for children. We also take photographs. We'll do pulp vitality testing. So this is typically for older patients because younger kids may not understand, like, oh, tell me if this cold hurts, or do you feel the cold? So there's lots of, you kind of have to gauge if the testing is accurate or not. We'll use study casts, and then we also do the caries risk assessment. So that's what this form is here. And this can help us prevent disease by identifying children at higher risk for cavities. And what this is part of what I love doing, but we develop an individualized preventive measures and caries management strategy for each patient. And this can also help us determine how often the child should be coming in. So on average, it's about every 6 months, but say, for example, the kid has braces and they're really high risk all of a sudden because they're having a harder time with their hygiene, we may see them every 3 months. So it just kind of depends, but this is becoming more common for routine visits. Okay, so as I mentioned, these are a few of our chief complaints that we get when patients come in. So oral pain is a really big one. This could be from many things. Just some examples are if they have a cavity, if that cavity's led to an infection, if they have swelling in their mouth. Sometimes even teeth that are growing in can cause pain, or they may have mouth sores. So lots of different things can cause pain, and kids a lot of times don't want their parents to look. So we have lots of behavior management techniques so we can kind of help the parent figure out what's going on. Another chief complaint is loose teeth. So you can see in this photo, we call it an ectopic tooth, or also as parents call it shark teeth, where it kind of grows in behind the baby tooth and the baby tooth isn't falling out for some reason. So this a lot of times will scare parents, so they want to come in so we can look at it for them. And then, as I mentioned, dental trauma is really big with kids, especially at the ages where they're learning to walk or they're really involved in sports or outdoor activities. In the wintertime in Ohio, we would see a lot of like sledding accidents, but even sometimes we've seen like jumping on the bed or like just things like that as well. So an avulsion is where the tooth gets completely knocked out of the mouth. This is usually more common for adult teeth. The baby teeth often will actually get fractured if they get bumped in the mouth. And then a subluxation is when the tooth kind of gets bumped, but it's not really moved out of place. And then a luxation is where the tooth gets bumped so much that it's pushed in a completely different direction. So if you guys want to look over this, a guide that we used a lot in residency is called dentaltraumaguide.org. So that's kind of fun if you are interested in learning about that. Okay. So a little bit about the procedures that we do. So a big part of pediatric dentistry, which you guys probably saw from my journey I'm really into, is preventive dentistry. So this is our cleanings, doing sealants to prevent cavities in the pits and fissures of the teeth, and going over detailed and personalized and oral hygiene instructions. And then our restorative treatment, that's where we're fixing the cavities. So fillings, stainless steel crowns, white crowns, buildups. And then orthodontics, like I mentioned, we do a little bit of that as well. Typically it's space maintainers. So you can see in the photo, this is an example of a lower lingual holding arch. So it's a passive appliance. It doesn't actually move teeth, but what it does is it's holding the teeth in place. We don't want to lose space for the adult teeth when they come in. And we do some oral surgery. So I guess we kind of do a little bit of all the specialties. So we'll do extractions where we remove teeth. We'll do oral pathology excisions to send them for biopsies, and we'll even do frenectomies. So that's like the lip tie, the tongue tie, we can release those as well. And then, as I mentioned, sedation is something that pediatric dentists can do as well. So oral sedation, that's a medicine they're going to drink. And a lot of times we'll do that with the nitrous oxide. So the patient is still awake, but they're a little bit sedated. So it's kind of like, some people are familiar with Valium for adults, kind of similar to that. There's also IV sedation and general anesthesia, but those are done with an anesthesiologist. Okay, so before I get into the cases, I wanted to go over some terms with you guys. It's a little bit different than adult dentistry. So the primary teeth or baby teeth are actually letters. So starting in the upper right, that's tooth A, and then going across the mouth, upper left is J. And then you go down to the lower left, so that's K, and you come back to the lower right, and that's T. And then, so similarly with the adult teeth, starting in the upper right is tooth number 1. That's your wisdom tooth, all the way around to tooth 16. Go down to the lower left, that's 17. And then over to the lower right is 32. Let's see if this will work. Okay, perfect. So the tooth surfaces. So there's the top part of the tooth. So in your front teeth, it's called the incisal edge. And then on your back teeth, that's called the occlusal surface. And so that's a lot of times where we'll do those sealants to protect the pits and fissures from developing cavities. And then the interproximal surfaces is the mesial, which is towards the midline of the mouth, and then distal is away from the midline. And then we also have the labial or buccal side of the tooth, which is towards the cheek or lip, which we call facial side. And then we have the lingual or palatal side, depending if it's the top or bottom of the mouth. So in the maxilla, that's called the palatal side, is facing the palate. And then on the bottom, facing your tongue, is called the lingual surface. Okay, and then a little bit of basic tooth anatomy. So the outer layer of the crown of your tooth is called the enamel. And then the second layer inside of that is called the dentin. And then the fun little part in the very middle of your tooth, in both the crown and the root structure, is called the pulp. So that's with your blood vessels and your nerves. Okay, and as I mentioned, behavior for children in dentistry is really important. This is kind of irrelevant in adult dentistry. I don't think they do this, but basically it's a behavior rating scale according to the patient's attitude during dental treatment. And this is really important because this helps us kind of decide how we're going to do their dental treatment. So if you have a 2-year-old with a lot of cavities, even though it's age appropriate that they're crying during your dental exam, you're not going to be able to safely fix their cavities with them awake. So that would be like a 1 or a 2, depending on how much they're crying, even though it's age appropriate. So then you could refer them to do a general anesthesia where they would be completely asleep. So that's just one example. Okay, and then we do kind of have a separate language in pediatric dentistry. We call them euphemisms, and this can vary. Every dentist has their own ones. Just a few examples. So caries or cavities, we call them sugar bugs. And due to COVID, most kids know what germs are now, so it's a little bit easier to explain the sugar bugs in their mouth. When we do extractions where we take out teeth, we call it sunshine. Our high-speed handpiece, we call it a special toothbrush or Mr. Whistles because it makes a whistling noise, and we kind of show them on their hand. That's tell, show, do. It's a special behavior management technique in pediatrics. So there's just lots of different fun names, and I change it all the time. Sometimes the numbing medicine is sleepy juice. Sometimes if my patient likes Elsa, I'm like, Elsa's gonna freeze your tooth. And so there's just lots of different fun things, and every day is different, and kids are really funny sometimes. So you can have a lot of fun with this part of it. Okay, and then the last thing I'll go over before we jump into our cases is the occlusion of teeth. So this is the primary molar relationship, and this is also a significant determinant for the position of the first permanent molars when they erupt, and eventually their occlusion as well. So it's kind of how the teeth come together. So a distal step in the baby molars will actually usually lead to a class 2 permanent molar relationship. And so this is a case where they'd probably end up needing braces. And then a flush terminal plane, you can kind of see that line where they're in line perfectly. So half the time this will lead to a class 1 occlusion, and then half the time you'll also get that class 2 occlusion in the adult molars. And then a mesial step a lot of times can lead to a class 1 occlusion, but if it's an exaggerated mesial step, this can actually lead to class 3 or that typical underbite. Sorry, this is another picture where you can kind of see the different molar relationships in the baby teeth. And then there's lots of other factors that can affect the occlusion too. So if you have cavities in between the teeth can actually move together. If you lose a tooth early, that can cause the teeth to shift. If you keep a baby tooth too long, that can affect the occlusion of the adult teeth. So there's lots of factors that go into that. Okay, let's jump into our cases. So the first case I'll be going over is a 9-year-old male patient, and he presented for treatment of recurrent caries in his upper left quadrant. A recurrent cavity means they've already had one cavity on the tooth, and now for some reason they've developed a second cavity on that tooth. So it's really important you always go over the medical history, and luckily for this patient, he's nice and healthy. He doesn't have any allergies, and he's not taking any medications as well. That's really important for us because our treatment plan was to give him nitrous oxide or the laughing gas. So we want to make sure there's no interactions with any medications he's taking. And so we do kind of our workup here. So our clinical examination where we looked at the teeth, you can see the circle here where the cavity is on the tooth. And then we also have our digital x-ray where we can see the whole. Can you guys see my mouse? So this is the little cavity you can see on that baby tooth. And then you can also see the adult teeth above there. So he still has full roots on his baby molar. So that's why we're going to go ahead and fix this cavity. So sorry, we're really busy, but I did manage to get some photos for you guys. So this is what our operative setup would look like. So this is, here, you guys can see the mouse, right?
Yes.
Okay. So this is what we call our dry shield, which is an isolation device. And so I have another photo so you can see how it works in the mouth. But it includes a bite block to help keep the mouth open. And it's also connected to our high-speed suction. So it'll take all of the water out of the mouth for us. And this is our nitrous oxide nose for the laughing gas. And then this is our syringe and needle for the numbing portion. This is our little burr block. So we use lots of different burrs depending on what kind of restoration we're doing for the tooth. And then this is just our basic setup of our mirror, our explorer, and then just our cotton forceps here. And then these are our hand pieces. So this is the one I mentioned. This is Mr. Whistles. So that's the high-speed one that we typically remove most of the cavity with. And then this one is our slow speed, or what we call Mr. Bumpy. So it doesn't usually blow wind or air like the high speed does. And it kind of makes a bumpier sound. And then this is where our air and water comes out of. And then in addition to the Nemo tail that I'll show you in a photo later, we do also have Mr. Thirsty that'll take the water out of the mouth. And then this one we call Big Ben, which is our bigger vacuum to take water out. And then my assistant also has her own air water syringe. These are some other specific instruments we'll use specifically for filling. So this is a little ball burnisher that we use to push the composite or the filling material into the preparation. And this will actually hold our articulating paper, and articulating paper we use at the end of the restoration to check that their bite is the same as before we started, or as close as possible. And then this is kind of everything that we would use for filling. There's also some other things in there, but I'll touch on those in the other cases. So let's see, so we have some floss here, so we can check in between the teeth, make sure we can still floss after putting the filling in. This pink stuff, this is Carrie's indicator dye, so we can use that to see if there's any cavity left. And then this is limelight, so we use that. It's sort of a medication we put underneath the filling. And then this is our etchant, or what we call blue shampoo for the kids. So it kind of prepares the tooth to receive the filling. And then we use these little micro brushes, and we put the bonding agent in a little container because it is light cured. So we want to make sure that the natural light from the room is not curing the bond before we put it into the tooth. And then this is our composite. So this is how we put the filling material in. And then we also have sealant material. So if there's part of the tooth that we're not including in the preparation to receive the filling, I do like to seal the rest of the grooves of the tooth to make sure that they're less likely to get another cavity on that tooth. And then this is flowable. So it's similar to composite, but it goes on as a liquid. So some people use that as well in their fillings. Okay, so intraoperatively, this is what I was mentioning. So we do have TVs on the ceilings at our office in all of our rooms and for all of our chairs. So the kids just get headphones, and they are Bluetooth, so luckily there's no wires there. We put sunglasses on for them if they want, because the light is super bright, and also protect their eyes if there's any water or anything. And then this is the nitrous oxide, or laughing gas nose, where they're receiving the nitrous oxide. And we do titrate it, meaning we give them a certain amount based on what level we want them to receive. And then this is that dry shield that I was mentioning. And this is newer technology, and I love it. You don't have to give as many injections as you would with a rubber dam isolation. And like I said, if my assistant's mixing something or getting something else ready for me, I don't need to have her there doing the suction right at that moment, because this dry shield is actually suctioning also for me. And so it's pulling the cheek away, it's keeping the tongue away. So as long as my patient doesn't have a gag reflex, this is a really great option for isolation. Okay, and just a little bit more technical, but this is an example of what a tooth preparation would look like. So let's see. Okay, so we were doing tooth J, so that would be the second primary molar in the upper left. So the mesial is towards the midline, so it's in between the tooth, the proximal surface, and then the occlusal is the top part of the tooth as well. So this is an example of what a preparation would look like. And then this is an example of a matrix band, and this is what we put around the tooth. And that's really important so that when we're putting the composite, the filling material into the tooth, we're not gluing the teeth together. Okay, so this is when we're all done. So you can see in the mirror here, we put a little filling. Sometimes there's a little bleeding. A lot of these kids get cavities because they're not flossing, so they do have a little bit of gingivitis. So putting that little matrix band can cause a little bit of bleeding, so you have to make sure we're controlling that when we put our composite filling in. But we finished putting the filling in. Luckily, he was a Frankel 4, so if you remember, that was the best behavior. So he did really well with the nitrous oxide. And then we go over the postoperative instructions with the patient and the parent. Kids a lot of times forget that they're numb, or they don't understand the concept that they're numb and they can't feel things, so they continue to try and bite themselves or scratch themselves. So we usually give them gauze to take home to bite on, so there's a lower chance that they'll end up hurting themselves. And we tell the parent to watch them as well. A little bit of children's Tylenol or Motrin as needed in case they're a little bit sore. Typically they don't need it though after filling, it's more for extractions. And then the bite or the occlusion, like I said, we check it with that blue articulating paper. The difference between adult teeth and baby teeth move a little bit, so it's pretty rare that we have to adjust the bite, unlike you would with adult teeth if anything is off. And then usually the same day they can go back to normal brushing and flossing, and then we give the parent the contact information if they have any questions. Oops, skipped one, sorry. I moved the video camera so I could read part of it. Okay, so let's go into our second case. So this is a younger patient. She's a 4-year-old female, and she presented because she had cavities in all 4 quadrants of her mouth. So today we were treating her lower right quadrant. Also, she was nice and healthy, no known allergies, no medical conditions, and not taking any medications. So we had already done, you can see we already did a filling and crown in her upper right last time, and she did really well with the nitrous oxide. So there's a pretty good chance she was going to do well doing the same treatment the second appointment. I do always like to warn parents though, sometimes the second visit's a little more difficult because the child kind of knows what's happening. And so sometimes they develop anxiety about it before they come in for the second, third, fourth appointment. But luckily she does really well, so I'll kind of show you guys. So this is that bigger cavity, so that's why we ended up planning a pulpotomy, which is where we put a medicine inside of the tooth, and a stainless steel crown. And then on the smaller cavity on the tooth behind it, we did a mesial occlusal composite restoration. Okay, so just a few extra things compared to the setup with the first case. So we are doing a crown this time. So what we will be using, this is IRM. So that will go inside of the pulp chamber. I'll show you a diagram later. And so they mix it on this mixing pad. And then also we have these little tiny cotton pellets, and they have a medication called formocresol on them. So we would put that in to help control the bleeding and everything before we would put the IRM in. And then this big thing back here, this is actually to put the cement into the crown. And then these instruments, the crimper, the bite stick, and the Howe pliers are to adjust the stainless steel crown. So different from adult teeth crowns, which have to have an impression. They're usually either printed in the office or they're sent to a lab. So unless it's printed in the office, they usually have to get a temporary crown put on, and then they come back later to get the real crown delivered. With stainless steel crowns, we can adapt it during the appointment and deliver it at the same time. So it saves the child a visit. It's a lot easier, and it's a lot more durable as well. Okay, so intraoperatively, this is the little diagram I was mentioning. So we did the removal of the cavity, and we did the placement of the composite restoration on T, the back tooth first. And the reason is there's more bleeding from when you do the crown procedure. And it's really important when you're placing the filling that there's no bleeding, no saliva or anything. So we usually do the stainless steel crown second. Okay, and so then for the stainless steel crown and the caries removal, what we do is we use the burrs, like I mentioned, so it's different burrs typically than you would use for a filling. We'll remove the cavity, and a pulpotomy means we're just removing the top part of the pulp. Okay, and then these little cotton pellets, that's what we put the formal creasal medicine in, usually for about 5 minutes. And that's to kind of control the bleeding. And we want to have amputated pulp stumps. And then you can see when you take out the cotton pellets, it should look like two little black eyes is usually what they tell you to look for. And then after that, you take out the formal creasal pellet and you put the IRM inside of that chamber, and then you'll glue on the stainless steel crown on top of that. Okay, so like I mentioned, she was a Frankel 4. She did amazing. So you can see that we did a filling on this back baby tooth, and we did a stainless steel crown on the tooth in front of it. Similar post-operative instructions. The main difference is the glue does take maybe about 24 hours to finish drying all the way. So we do tell them to avoid sticky foods. A big thing for kids is gummy vitamins. We don't want them to pull the crown off right away. And then usually I have them wait to floss as well until the next day. And then because it was a bigger cavity, we want them to make sure that they're watching for any signs of infection. The medicine, while it does really well, it's not 100% of the time that it's effective. So if there's any problems, we want them to let us know right away. Okay. And then I think this is my last case I have, and then I'll go over some of the new technology we have in pediatrics. So this was an 8-year-old male patient that was referred to us from another dentist for treatment of an abscess in the lower left quadrant. I think I have it circled here. There we go. So this 8-year-old, he is nice and healthy, no significant medical history. So the plan was to do nitrous oxide, and then we would do an extraction of this infected tooth, and then we would place a lower lingual holding arch, or that space maintainer, the passive appliance. So we do have an x-ray. You can see this dark radiolucency. That's a sign of the abscess. And then clinically, we can see the abscess on the gum tissue as well. So we describe it as a little pimple or bubble on the gums. Okay. So our treatment plan, we are going to do the nitrous oxide, a little numbing medicine. We would remove the baby tooth. And then what we do is we actually will fit the bands on the first permanent molars, and we'll take an impression to send to the lab. So this is one of the few things we send to a lab. We don't make ours in our office. And then the patient will come back 2 to 3 weeks later for delivery of the space maintainer. I think I have, let's see my next slide. So yeah, this is what the baby tooth looked like. Okay, so different types of space maintainers. So the band and loop, so that's this one on the top here. So this is for unilateral tooth locks, and it can be in the maxilla or mandible. And so we fit a little band, and then there's a little loop, and you can either send these to the lab for a custom one, or you can make them chairside as well, the same appointment. And then what we were doing is a lower lingual holding arch, which is for unilateral or bilateral tooth loss, typically in the mandible. And you do need to have the lower permanent incisors and the first molars present. That's what you would glue the appliance onto. And then another option for the possibly you could use is called a distal shoe. And this is for unilateral tooth loss. And this is when you have premature loss of the primary second molar. And the reason is this shoe, this little part right here, it goes into the gingiva, and it acts as a guide plane for the permanent first molar to grow into place. And then once this tooth comes in, you can change it to a lower lingual holding arch as well. Okay, so this is a little photo. I think I showed it earlier, but an example of a lower lingual holding arch. Yes, this is an adult tooth model though. Okay, so pretty similar post-operative instructions again. Main thing I like to mention for extractions is sometimes the saliva can mix with the top part of the blood clot, and it can look like there's a lot of bleeding, but usually the bleeding will stop within the first 5 to 10 minutes. So we have them bite on some gauze to make sure they're not bleeding when they leave the appointment. And then we remind them it's important to come back for that space maintainer, because otherwise they may have some space loss, and it would make them more likely to need braces when they're older. Do we have time to go over some new technology?
Yes, absolutely. Go for it.
Okay, I just want to make sure. Okay, so I kind of went over this one already, but this is one of my favorites. So this is the dry shield isolation. Like I said, it does multiple things for you. There's even one called the Isolite. It actually even has light in it if you want that one. The reason we like the dry shield is you can actually sterilize it and reuse it, so it's a little bit more eco-friendly. Okay, and then I mentioned sometimes in our 30-minute appointment slots, we'll do something called silver diamine fluoride. So it's a 38% concentration, and it's a topical antibacterial and remineralizing liquid that's used to arrest cavitated lesions in primary teeth. It can also be used on permanent teeth as well. It does not eliminate the need for dental fillings or crowns to restore aesthetics and function. And originally it was used for tooth sensitivity. So this was approved by the FDA maybe 4 or 5 years ago, but it's been used in Japan and other countries for hundreds of years. So it's awesome that we now have access to this. A lot of times we can use this if we see a cavity starting and we know the kid won't be able to do dental treatment awake, and parents don't really want to do general anesthesia yet. And if they're not having pain, this is a really great option. It's also really good. This is an example of like a root cavity. So a lot of adults will get these. So it's used on a lot of elderly patients as well who can't get dental treatment. Okay, and then we do have white crowns in pediatric dentistry as well. They're usually made of zirconia, so they're a lot more aesthetic. The only downside, I would say, is the preparation of the tooth or the removal of tooth structure. It's not as conservative as with the stainless steel crowns, so there's usually not as much retention. You're purely relying on the strength of the cement that you're using to hold the crowns on. I like to put them on the front teeth though, but some people will use them on back teeth as well. And then a lot of kids do grind their teeth. So I have seen sometimes that they can fracture these, or they can fracture the opposing tooth in the other arch because their zirconia is pretty strong. So that's one of the downsides to that as well. But it's a really great option. It's a lot more aesthetic for patients as well. Okay, and then Hall crowns. These have been around for a while. There's pretty great science out on the success of these Hall crowns. I feel like it became a lot more popular during the pandemic though, because this entire procedure can be done without any aerosols created, which is really awesome. So basically what you're doing is you're cementing a stainless steel crown over a tooth affected by cavities, and you don't have to do any numbing, you don't have to do any drilling, and you don't have to remove any of the tooth structure. And like I kind of mentioned before, baby teeth, the bite can kind of adjust itself. So a lot of times, even though you're not removing tooth structure, the tooth will kind of settle back into a good occlusion. So this is a really great option. You usually just put, it's called a separator, in between the adjacent teeth, maybe for a few days before the appointment. You can technically even do it the same day, but you just have to wait a little bit. What you're doing is creating space for the stainless steel crown, and you just have to find the size, and you can just glue it right over. And by blocking off the cavity, there's no new food getting in there, there's no new bacteria. So there's a specific criteria for which teeth you can do this procedure on, but we've seen a lot of great success with this, and it's also really good for our kiddos who we don't think will be able to get numb, so if they'll have a hard time with the injection portion. So this is going to become more and more popular as well. Okay, and this is one I'm really excited about. Some of you may have seen this, maybe Jay, you've seen this if you're into environmental dentistry, but it's called hydroxyapatite, and it's a form of calcium that makes up 7% of your tooth enamel and 70% of the dentin in your teeth. So this is biomimetic, and it's biocompatible with your teeth, and it will actually remineralize or re-strengthen your enamel, and there's no known side effects. So fluoride, if you ingest a lot of it, so if like a kid ate a whole tube of toothpaste, it can be poisonous. And so sometimes you have to go to the hospital for that. And also if you ingest too much fluoride, you can get what's called fluorosis, which is permanent like white spots in your teeth. So sometimes we'll see that in adult teeth. Whereas hydroxyapatite, the studies are really good, and it doesn't have any known side effects. So I think we'll see a lot more of this over the next few years. It's been the go-to option in Japan already for over 40 years. So we're actually seeing a lot of companies, especially toothpaste tablets, they're using hydroxyapatite. So it's really good at preventing cavities as well. If you guys are interested in the studies, I can send that to you as well. Okay, so I'll just go over a few more tips for you guys, and then if you want, we can go over questions too. Okay. So this is just near and dear to my heart, but if everyone incorporates at least one sustainability practice, it can make a huge difference at reducing our impact in the world. So I'm hoping when you guys all get to school that sustainability will be part of the education so that the future of dentistry will be green. As I kind of mentioned before, make sure you take care of yourself. Dental school can be stressful, but you want to make sure that you're taking care of yourself first so that you can take really good care of your patients. And then also remember, dentistry is a journey, and even once you get that degree, there's still lifelong learning. Like I mentioned, lots of new things have come out since I've graduated dental school, and it's so much fun to learn about all the new things that are out there and how you can better serve your patients. Make sure you listen to your patients. I think the old school of thought was our job is just to treat the teeth and fix the cavities. And now there's much more of a functional approach to dentistry. So you want to take a personalized approach and kind of figure out what's causing their cavities or what's causing their teeth grinding and kind of help solve the root problems so that in the long term, they'll have better oral health. And then just remember, especially you guys are, most of you are probably in college, every dentist has a unique path, okay? So collaborate with your peers, stay connected with your mentors, and there's a place for everybody in dentistry if that's what you're really passionate about. Okay, so here's my contact information, and then I'll just leave this up if we want to go over some questions.
Thank you so much, Dr. Amanda, for your presentation. It was really, really detailed and informative. I've learned a lot. And thank you for taking the time to prepare this. If you don't mind, we have a couple of questions to ask you, if you don't mind. I have a question, and it's, how do you handle difficult patients if they're like running it out around, they don't want to sit in a dental chair? How do you deal with these patients?
Sure. So we have lots of different techniques we can use for that. A really common one is what we call the knee-to-knee exam. So this is pretty common with our little kids. And so we actually have them sit on mom or dad's lap facing the parent. And so they'll wrap their legs around the parent, and then they lay their head back onto the dentist's lap. So they're looking at their parent instead of us. And then the parent can kind of help hold their hands if they're wiggling around, and we can kind of stabilize their head and take a look. And especially if they're crying, we usually get a really great look at all of the teeth, and we can do a pretty thorough examination in that position. So that's one great technique. That's probably one of my favorite ones. Yeah.
Thank you. I like how you're using their crying mouth examine. That's a good approach.
You work with what you get with kids, so.
Yeah.
Thank you, doctor. So another question that I have personally would be, what is your suggestion on a good way to like remember numbers and letters of teeth?
Sure. So I would just say lots and lots of practice. Like even in conversation, my husband now knows I'm like, you got a little food between 7 and 8, like, and you can come up with little stories too. But it really, I remember in the beginning of dental school, I was like, oh my gosh, there's so many surfaces. Like, how am I going to remember all of this? But in the end, the clinical side and the procedures and the numbers and letters, all of that gets easier with time. So it really just comes from practice. And you will also get little typodonts or tooth models when you're in dental school. So you'll have those that you can actually study on a physical model, which helps as well. But yeah, you can always you'll have lots of friends in dental school going through the same things. So you guys kind of, people after you graduate are like, wow, dentists really talk about teeth a lot together, but it's like, that's what you guys just kind of do. So it will become second nature, I promise.
Thank you.
Thank you, Dr. Amanda, for sharing your response. Our next question is, what do you like most about pediatric dentistry?
Oh, it's so hard to pick just one thing. I would probably have to say my patients are my favorite thing. Kids are so funny, and I have the most fun at work with them, and they're really resilient as well. So even if they're crying, they don't like the exam when you're taking a look at their teeth. Right afterwards, as soon as you're talking about stickers or toys, or they're playing with your like type it on your dinosaur, like we have movies playing, so there's lots of fun things, and they're smiling and they're laughing and they get excited to come to the dentist. That's my favorite, is when parents tell me they've been so excited to come in and see you. So we try to make it a really fun experience for them. And so I mean, especially during the pandemic, parents are like, we haven't really gotten out of the house. Like, we've been hyping up the dentist for like 2 or 3 weeks. So the kids have been really excited lately to come in. So they definitely keep my day exciting. And so I love it. And I also get to kind of see them grow up, because I get to see them from when they're babies all the way usually through high school, unless they have adult dental needs and we have to graduate them early. So we get to form really great relationships with them. So, and then we do see them quite a bit more than like their pediatrician would, because we're seeing them at least twice a year. So it's really fun to get to see them grow up.
Thank you, Dr. Amanda, for your response. Another question we have in the chat: can you provide tips on writing personal statements?
Sure. So for personal statements, I would just kind of do a brainstorm and just kind of think about what your main points are that you want to talk about. And in your application, you're going to already touch on a lot of other things. So trying to include something that's not already in your application. And then write a few drafts. So just spend a few different days, if you can, writing 1 to 3 drafts, I would say, and then kind of mull it over, think about it, and see which one is your favorite, and then send it to people if they're interested, if they would help you look over it and kind of see which one they find the most interesting. If you guys want to send me your personal statements, I'm happy to read them as well. I have my email here, but yeah, I would just say give it a few attempts and then kind of see which one's your favorite. And you may have favorite parts in different versions, and then you can kind of combine that as well.
Thank you, Doctor. So another question we have for you today is, what did you like during your time in dental school?
Oh, that's so hard to pick one thing. So I have so many of my best friends I made in dental school, which is kind of crazy because it's after college, right? But I have so many great friends from that time, and it's because you form this special bond because you're all in the simulation lab for so many hours together. And then like if you have time off, you guys all have the same time off together, like after finals or when you have your school breaks. And then you also, know what you're going through together. So when you're really stressed during finals, or when you're learning how to do your first wax up, or you're getting to see your first patients, you have all those special memories together. So that's really, really fun. And then also I really loved going on the dental mission trips. So I would say if you have that opportunity, definitely take it if you can.
Cool. Thanks.
Thank you, Dr. Amanda. Our other question that we have is, how would you describe your work-life balance as a pediatric dentist, with your passion for sustainability?
Sure. So, I mean, first out of residency, because in residency, you're used to working every day. And so I was working 6 days a week, and I was driving to multiple different practices. But once I got through, like, okay, I'm working now, I'm a dentist. So I found the practice that I love the most, and we actually have a green team at work. So a bunch of my staff is excited about sustainable dentistry as well. So that's been really fun. And like I mentioned, I usually work 4 days a week. So I have one day I can kind of focus on my sustainability efforts. And sometime this year, we'll actually be launching a sustainability dentistry Facebook group. So dentists or students in dental school will be able to join this group. So definitely keep a lookout for that. But like I said, dentists have a pretty good work-life balance, but it's all what you make of it. So some of my friends like to work 5-6 days a week. Some of my friends like to work 3 days a week, teach at a dental school 2 days a week. Some people are parents, and so they work 1 or 2 days a week, and then they're a stay-at-home parent the other days. So it's all, the nice thing about dentistry is it's very flexible, and there's lots of options.
Thank you so much, Dr. Amanda. Another question is, what did you look in dental schools when you were applying?
Sure. So I think my journey was a little different because I really wanted to go to Dagoni, but the main thing for me was I wanted to stay in California, at least for dental schools. So I only applied to dental schools in California. But looking back, I would say you want to make sure that you like the faculty that are at the dental school because they'll be teaching you. So if you're a hands-on learner, you want to go to a dental school where you get a lot of hands-on experience. If you're really interested in research, you would want to look for a school that has a really big research component or a lot of mentors who are doing research that take on students. And then the other thing too that I'm really glad was Dagoni had the humanistic model, and I think that's becoming much more widespread. Most dental schools are that way now, but hearing stories of when I went to residency of what other dental schools were like, I was like, wow, I got really lucky that Dagoni had the humanistic model. So definitely what I would recommend is talking to students who are already at that dental school and seeing how they feel about their faculty, how they feel about getting enough experience in the dental clinic, access to patients, and then also how they feel at their balances as a student.
Thank you, doctor. So another question we have for you is, how do you ensure or provide a successful day in your office between you and your team or colleagues?
Yeah. So I would say communication is the biggest thing. So in dental school, they're teaching you a lot of the clinical side, and then even at least at Dagoni, they taught us some of the business side of that as well. But I think having communication and having mentors as well. So, for example, there's 2 doctors in my practice who've been practicing for like over 10 years compared to me. So I learn a lot from them if I have a difficult case or a parent that's wanting something explained in a different way. So I'm always learning from my colleagues. And then, like I mentioned, in a typical day, we always start the day with a huddle so we can communicate between the front office, what's going to be going on in the clinical side of the office. And then we also have, I don't know if you guys have heard of this, but it's called Slack. It's kind of like an instant messaging system that we use within the office. So we can message from within the treatment room or from the open bay to the front desk or to another assistant if we need them to bring something or if we're running behind. So I just say communication is really, really important.
Right. Awesome.
Thank you again, Dr. Amanda. Our last question is, do you have any advice that you would like to share with us or anything that anything you wish you knew before you attended dental school?
Sure. Let's see. What would be the main thing? I would say while you're going to work really hard, just make sure you're also enjoying the journey. Like I mentioned, a lot of the actual clinical dentistry just comes with practice and with time, and you will definitely put in your time in dental school and you have the rest of your life to improve upon skills that you really want to focus on. Dentists don't have to do every procedure. You can pick which procedures you like doing, and you can really become excellent at doing those procedures. And those people that you're in dental school with, they will be the people that if you have questions, you can reach out to them. Say you have a gum question, you can call them, message them. But like I mentioned, the dental community is really small. So just make sure you're forming those networking and those friendships. And I mean, it's really fun getting to go to the continuing education courses and learning what is new out there, but you also get to have reunions with all of your dental school classmates too. So just enjoy the journey.
Well, that ends our questions for the night, Dr. Amanda. Again, thank you so much for preparing this presentation and for your kind advice. We enjoyed having you today and learning from you. For everyone that is still watching, we will be posting our post-quiz session in our group meet chat, and you'll have 24 hours to take the quiz. Again, thank you so much, Dr. Amanda, for joining us tonight.
My pleasure. Thank you for having me.
Thank you.
Thank you.